The patient is a 62-year-old retired businesswoman who has had multiple bridge work done in her mouth many years ago. She is allergic to seafood, taking medication for cholesterol, but otherwise has a clear medical history. Her chief concern includes sensitive teeth, especially to cold and air, and there's air escaping from her front teeth when she speaks. Food impaction often happens under her bridge work, and when attempting to floss, she often breaks them. Findings include marginal leakages and secondary caries at all bridges. Endodontic status of teeth 17, 14, 25, and 36 were questionable. They were referred to an endodontist for assessment, and the teeth were endodontically treated during the duration of the treatment plan. The patient did mention about her interest in implant therapy and is hoping to receive fixed and individualized teeth, where the implants will be used to replace missing pontic teeth at her bridge work. Her basic periodontal examination was scored as 2, where plaque retentive factors include poor fitting margins on her current bridge work. When in maximum intercuspation, all occlusal contacts appear stable and all teeth are meeting. However, when observing lateral excursive movements, group function is observed on both sides, and tooth surface wear facets were observed on her natural molars. The occlusal anatomy of her bridgework appears to be flat. Clicking and crepitus of her temporomandibular joint was not observed on palpation. The patient has a skeletal class 2 profile and all her facial thirds appear to be in proportion. She also mentioned that her current teeth appear too square and masculine and rather opaque in color. Treatment plan options were discussed and patients' expectations were informed, and complications and treatment alterations may occur at such a complex treatment plan. It is divided into 2 stages, where the first stage will involve the removal of disease and stabilization. This would include caries control and supportive periodontal therapy and stabilization of her oral health. Light body silicone casts were made from alginates taken after sectioning of the bridges. This was also to make the provisionals. The provisionals were duplicates of a previous bridge work, and we are able to observe her envelope of function better, as pain and symptoms of discomfort were eliminated. This may appear as a conformative approach, but during the period of a month, alterations of her provisionals were made and deemed as a reorganization of occlusion approach. The discussion of treatment options are all laid down in the write-up. The comprehensive treatment plan would involve full mouth rehabilitation with dental implants and individualization of crowns and the reorganization of the patient's occlusion. Here we see the fabrication of the surgical stent, where the maxilla will accommodate 5 dental implants and the mandible 1. The patient has expressed anxiety prior to her first dental implant placement surgery, and only 1 implant was placed in the first procedure at the edentulous site of 4/6 under local anesthesia. Post-operatively, the patient has only complained of swelling and mild discomfort, and ever since then was confident to proceed and continue the whole treatment process. The implants are placed following the Brennemark protocol, where titanium endosseous implants are placed into the planned sites of the alveolar bone and left to heal by primary closure and to osseointegrate for 3 to 4 months. Surgery is done in an environment as aseptically achievable under local anesthesia and oral sedation of midazolam and 600 milligrams of clindamycin as an antibiotic prophylaxis 1 hour before surgery. Sites anticipated where insufficient bone quality and quantity are grafted with exogenous bone particulate material and collagen barrier membrane. The stage 1 surgery is only done once the endodontic status of the teeth treated by the endodontist has been stabilized to minimize any risk of infection from adjacent teeth. Healing was uneventful and the provisionals are cemented back and her oral functions are continuously monitored. Interestingly, the provisionals were much more comfortable than her previous bridge work as reported by the patient. Only an incident of debonding occurred at the lower right provisional bridge, once due to inadequate bulk and cementation of the 4-5 abutment tooth, and it was cemented back. During this few months of healing period, the patient has started to express her views and details on how the teeth would look like, using the provisionals as a reference. Second stage surgery is then carried out where the implants are recovered and sulcus formers placed to sculpt the gingival architecture to satisfactory emergence profiles for accommodating the future definitive crowns. We take the opportunity to use a magnetic smart pack to determine the ISQ, or implant stability quotient, which will be monitored from time to time until the completion of the treatment. This shows the percentage of implant surface also integrated with bone, which should exceed 65, and all have exceeded 65 and increase to 70 to 80 as secondary stability becomes more pronounced. At the anterior region, the sulcus formers were then changed to a wider diameter and the anterior provisional bridge has been relined with composites to create ovate pontics to further condition the soft tissue profile into creating pseudopapillae. An alginate impression of the upper and lower jaw with the provisionals were taken to create index putties for the crown preparation stage. The models are also poured and sent to the dental technician and ceramist. It is used as a communication tool in fabricating the definitive restorations. Later on, the other bridge works have been sectioned and posterior natural abutment teeth have been converted to individual abutment crowns with the sulcus formers exposed for ease of retrievability. This is only for a short period of 2 to 3 weeks. Once soft tissue stability has been achieved, The crown preparation and impression stage are made together in the same visit. Abutment teeth are prepared according to the King's College Dental Institute Crown and Bridge Preparation Protocol, with the index putty with the aims of achieving a 6-degree taper and adequate restorative space for the crown material. We will be using full ceramics, and 1.5 millimeters of restorative space is needed. Occlusal clearance is not made as the teeth already have been prepared previously, and focus was on the margins where preparations are made equigingival, not violating the biologic width, and deep chamfers were further fine-tuned during the double chord retraction stage. One tip to take note is that during the tooth preparation, the implant sulcus formers should be adequately intact, as in not to be in the way of disrupting the burrs in the preparation of teeth, and protecting the implant from having debris from falling into the implant screw hole and contaminating it. Impression posts of the implants were closed and open trays, used and chosen according to the ease of angulation and patient's limited mouth opening. And the special trays have been made accordingly to accommodate them. Heavy body and light additional silicones were used as impression materials in a one-stage technique. It is then removed and inspected. Residual retraction cord that was deemed valuable is left behind in the impression, as not to jeopardize or distort the impression material that has been set. It is then disinfected and with clear instructions sent to the technician and ceramist. Bite registration is taken one side at a time, with the patient wearing provisional bridges on the other side of the mouth when the patient has been asked to bite in maximum intercuspation. The corresponding bite record is taken again with the opposite side wearing the previous bite record. Included are also clinical pictures and shade guides for reference, which are stored in a thumb drive together with the lab form when it is sent to the dental technician. The crown material of choice would be full ceramic, as the patient has a high aesthetic demand. Posterior teeth, the premolars and beyond, utilize monolithic zirconia that are machine milled. They can withstand over 1000 megapascals of force, and being relatively opaque, is able to cover the titanium alloy abutments and appear natural with the conditioned gingival emergence profile. Anterior crowns and implant bridges are made of layered ceramic with zirconia core. This provides a complement of strength and also translucency and aesthetics. The arrangement of the prostheses, including the implant abutment and index pattern resin keys, are catalogued and arranged in an organized way to minimize confusion during the cementation stage. At the appointment, once the provisionals are removed, a 2% chlorhexidine pumice slurry are used with a prophylaxis brush to clean the abutment teeth surface area and remove residual temporary cements. The 2% chlorhexidine also helps in increasing the bond strength of resin cements. The implant system used is ankylose, which relies on a tapered connection at the implant abutment interface, and care has been taken to keep that interface clean. A syringe with chlorhexidine mouthwash is used to irrigate the implant screw using a microtip. The implant abutment is then torqued at the correct angulation and orientation using the red pattern resin. Certain sites require administration of local anesthesia as gingival discomfort is inevitable due to the subcrestal bone placement of the implant system. The abutment hex screws, after torquing, are covered with gutta percha sticks and cavet for ease of retrievability. The ceramic crowns are silanated and cemented with resin-luting cements, and the implant crowns cemented with temporary non-eugenol cements. They are then flossed, tidied up, and cleaned to be certain and reduce the risk of periscementitis. At the patient's request, despite having a relatively low smile line, she would like to have some pink gingival profile at the anterior teeth, and some pink composites were added. Attention has been given on the flossability and the patient's ability to keep it hygienically clean. There is a possibility that the anterior implant bridge ceramic work may need to be redone with pink ceramics in the future. The patient would also want her lower anterior teeth refurbished and to look young again, and direct restorations in the form of composite resins were used to restore worn-out incisor surfaces, shaping them with mamelons for more youthful appearance. No tooth reductions were made. Composites were solely bonded to etched enamel. I also took the opportunity to re-examine the patient's lateral and excursive movements and occlusion, and they again finely tune, reassuring that her occlusion is mutually protected, involving anterior guidance with canines at the stops, with posterior disclusion on lateral excursions. The finished teeth are then polished with the Jiffy composite polishing system according to manufacturer guidelines. Some stained flowable composites were added to create a more lifelike and natural appearance on the incisal edges. Blue composites give the illusion of translucency, and the opaque white give hints of characterization from hyperplastic enamel.